Good afternoon, Ralph community, and welcome back to Wellness Wednesday, where we share practical wellness tools and techniques from experts on the topics that are most important to patients, survivors, and caretakers alike. I'm Erin Kuhn-Krieger, and I'll be moderating this afternoon's session, The Genetics of Pancreatic Cancer. What do you need to know? But before we get started, I wanted to say thank you on behalf of the entire foundation for the generous support that we received in last month's Dashing Together virtually event. We are thrilled to announce that we raised almost $160,000, which will go toward Ralph's mission of research, resources, and support for the patients, survivors, and their families affected by pancreatic cancer. We once again saw the strength of our community and truly could not do it without you. Now, a couple of housekeeping items before we get started. Please ask questions throughout the session in the comment section below, and we'll get to all the questions at the end of the presentation to make sure that we get to everybody. Today's speaker is Dena Goldberg. She's a licensed and board certified genetic counselor located in Los Angeles. So I'm going to let Dena go into her impressive credentials, but I did want to share that she recently left her clinical role to work full-time on Dena DNA in order to spread awareness of medical genetics through media and marketing techniques not typically used by the medical community. Welcome, Dena.
Hi. Hi, thank you so much for having me. I'm really excited to talk about this today because it's something I'm really passionate about. So let's jump right in. Okay, let me share this. Okay. All right, so today we're going to be talking about the genetics of pancreatic cancer and what you need to know. Now, the first question I want to answer, just to get it out of the way because I get this so much, is what is a genetic counselor? And before I answer this, you should know that most doctors and other healthcare providers get very basic, if any, genetics training in medical school. And genetics is always changing. Whether it's our knowledge of genetics or the way that we incorporate it in healthcare, it changes every few months. And so genetics is the future of personalized medicine, and any healthcare team working with genetics really needs someone who understands this ever-changing field. And that's where genetic counselors come in. So the roles of genetic counselor is that we stay up to date with not only the latest research and recommendations, but also with genetic testing and which laboratories are offering which genes at which prices to get you the most affordable and appropriate testing. We translate complex information to patients, as well as communicate with healthcare teams. And we do all of this in a way that is ethical for both patients and their families. So it's the only specialty of medicine that we're not just taking care of one patient, we're taking care of the whole family. So hi, I'm Dena, and I'm a genetic counselor. I formerly was the Gordon and Betty Moore Endowed Counselor of Hereditary Gastrointestinal Cancer Prevention at UCSF in San Francisco, where I was a member of the UC Pancreatic Cancer Consortium and did research in pancreatic cancer and pancreatitis. And I recently, as Erin said, left my role there to pursue my personal brand full-time because I realized that there are a lot of people that didn't understand medical genetics, and I hope to one day have a television show to teach everybody about it. So my social media is here. Feel free to Instagram, tweet, or even add me on TikTok. Okay, so what did you all come here today for? The pancreas. But what is the pancreas? Well, the pancreas has two main functions, and those are digestion and regulating blood sugar levels. And to do this, there are things called glands or different systems of the pancreas. The first is exocrine, which produces enzymes that combine with bile for food digestion, and this is released into the digestive system. And then endocrine, and this is our hormones that get created by the pancreas, so insulin and other hormones that control blood sugar levels and are released into the bloodstream. So the pancreas really is doing two different things to the digestive system and the bloodstream. And the reason this is important is because when we think of the word pancreatic cancer, it can actually mean any of these things. Now, most most of the time, it's referring to an exocrine type of pancreatic tumor, which is the majority of tumors, over 90%. And most of those are what we call pancreatic ductal adenocarcinomas. We call them PDAC or PDAC. And that is most of the time what people are referring to when they say pancreatic cancer. But there are other tumors as well. And much less common, there's something called a pancreatic neuroendocrine tumor, or a PNET. And the reason this is important to know is that the prognosis, the treatment, and the genetics are very different depending on which type of tumor someone has. So that leads me to my first tip, which is if you are being evaluated for a personal or family history of pancreatic cancer, try to get a copy of the pathology report to share with your provider, because as I said, it's really important to know the difference. Okay, second question, what causes cancer? Well, when we look at it from a genetics point of view, we know about 10 to 15% of all cancers are hereditary, and about 20% are familial, and the rest are sporadic. But what does that mean? Well, sporadic cancers are the most common, and this is when we see a more common type of cancer in an individual at an average or older age for that type of cancer, and there's usually no family history. These are usually caused by environment or some sort of exposure or lifestyle, so like smoking, chemical exposure, radiation, things that we just don't know. Sometimes just some bad luck. And then we have familial. This is when we have two people in a family with similar cancers at average or older ages. And this is likely due to a mix of shared genes and environment together. So there's no one factor that causes these. It's really multifactorial. And then we have hereditary. This is when we see multiple generations of cancers that may go together with a certain syndrome at a younger than average age for those types of cancers. And this is where my job comes in, to try and figure out if a family fits this pattern. And the reason we want to know this is because these are caused by single gene mutations or genetic changes that cause disease that get passed from parent to child. So what are cancer genes? This is something that we hear a lot. I see it all the time in the media. And in every cell, we have about 20,000 genes. And a handful of these genes are called cancer genes. But surprisingly, cancer genes, what a gene does is it's a recipe for a protein. So any gene we have, whether it's the cancer genes or any gene, just creates this protein. And when there's a problem in the recipe or when there's a change, it may create the wrong protein or no protein at all. So that's really the basics of what genes are and what genetics is. So cancer genes, surprisingly, are good genes. We need them to protect our cells from becoming cancer. The issue is when there's a change in those recipes and that gene can no longer function, it can no longer protect our cell from becoming cancer. So that's when we call cancer genes, they're good genes. So when we think about the way our genes are passed down, we get 2 copies of every single one of those 20,000 genes. We get one from mom and one from dad. And when we have children, we pass one of our copies and our partner passes one of their copies. So when we talk about sporadic cancer, so most people are born with all of these cancer genes working correctly. Now, as we get older, the mechanisms that keep our genes in check may just randomly stop working. And so let's say this person over 30 to 40 years acquires a mutation in one copy of one of these genes. That's okay, because there's a backup copy. So that cell that has that faulty gene now still has the other copy that can do its job. But then another 30 or 40 years goes by and a second mutation happens. Now that cell no longer has that protection and may become a cancer. Now, that is what happens with most cancers. Now let's imagine somebody has a mutation that they're born with. So they actually inherited it from one of their parents. Now that every single cell in their body will have that first mutation. And so that first 30 or 40 years goes by and they acquire their first acquired mutation. Now that cell, because it didn't have a backup, may turn to cancer in less time than if they had been born with 2 working copies in all of their cells. So this is really the way that hereditary cancer works. It's very simplified. It gets a little more complex, but I think it's a really good way to kind of think about it. So when we talk about the chance of somebody inheriting one of these mutations, not everyone will inherit it, even if you have a parent with it, because there's still a good copy. So every time a couple has a child, when one parent has a mutation, there's a 50% chance that each child will inherit the change, and a 50% they will not. And anyone who does not inherit it will not be able to pass it down. So if you don't have a mutation, you can't pass one down. They don't skip generations. So when we talk about genetic testing, a lot of times when I used to have patients that would come in, they'd say, oh, well, I already had genetic testing. My oncologist ordered it for me. But there's actually two types of testing. And one is tumor genetic testing. And that is when we look at the tumor to look for any changes that cause that tumor to become cancer, so we can target the treatment for that tumor. But it doesn't tell us how that tumor became a tumor. So we don't know if that person was born with a mutation or they were born with two working copies. And so what we do is something called germline genetic testing. That looks at someone's blood or saliva to be able to tell what their genes look like to begin with in their healthy cells. And that can be done on individuals who don't have cancer. So that's how we can predict if somebody is born with this risk, versus the tumor testing needs to be done, it can only be done on a cancer tumor. And so the germline genetic testing not only helps us figure out the cause of a cancer, but also may find risk for other cancers associated, may find risks for other family members and what they're at risk for, helps us, it may change a treatment plan, and gives us clues on how that tumor may develop and what the behavior might look like. So there are two different types of genetic tests, and today we're really going to focus on germline. So germline testing, as I said, is done by blood or saliva. And when we talk about the different results that we can get, there's a positive, and this can be confusing because most people think positive good, but positive in genetic testing means that a mutation or pathogenic variant, meaning disease-causing change that affects the protein being made by the gene, was found. So that's what positive means. Negative means that all of the genes that were looked at were just normal copies, and we know the correct protein is being made. Now, sometimes we have a new copy of a gene that we haven't seen much before, and we don't know if the correct protein is being made or not. So we call this a VUS, or a variant of unknown significance. And so many times when people test, they'll have a few of these. They don't really mean anything. Most of the time they get reclassified. So we really only take action when someone has is positive for a pathogenic variant. We don't really consider the VUSs. We consider them kind of more like negatives. Although we watch them over time, because as more and more people are tested, that variant may become normal variation because we learn more, or it may be reclassified as pathogenic. So it's another reason to keep in touch with a genetic counselor who can update you if you have any variants. So when we talk about risk factors for pancreatic cancer, I'm sure this group knows all of this already. Smoking, pancreatitis, alcohol, obesity, diabetes, these are all risk factors that aren't necessarily in our control, and some of them are, the smoking and alcohol. But the genetics is a big risk factor as well, and sometimes it can be a bigger risk factor than any of these others. So when we talk about the different syndromes for pancreatic cancer, the most common one people know about, because it is the most frequent, is this one we call HBOC, or hereditary breast and ovarian cancer syndrome. Really, it's not a great name because it really involves pancreatic, prostate, and melanoma cancers as well. And this is the syndrome caused by mutations in the genes BRCA1 and BRCA2. And of note, those who have Ashkenazi Jewish ancestry, which means European Jewish, 1 in 40 will have a mutation in one of these genes. And so whenever you fill out a questionnaire when it comes to genetics, you're always going to be asked if you have Ashkenazi ancestry, and this is why. So the most common cause of pancreatic cancer in somebody who has Ashkenazi ancestry is usually from a mutation in one of these genes. The other syndrome is Lynch syndrome, and this is one that I specialized in at UCSF, and this is caused by a mutation in one of these 5 genes here, and it's actually, it also increases risk for colon and uterine cancers, as well as several others. And then we have something called FAMMM, which is when somebody has many melanomas and moles and also pancreatic cancer. So when you hear about the link between melanoma and pancreatic cancer, it's usually because someone has a hereditary genetic change in one of these genes. And then there's something called Pitts-Yager syndrome. This is a lot more rare, but it has a very high risk for pancreatic cancer. And then PALB2 is a gene that was discovered later on after BRCA1 and 2, but really is in the same pathway. So it mimics HBOC in many ways. And a lot of people who were previously only tested for BRCA1 and 2 went back and got tested for PALB2, and many of them were found to have a mutation if their family history looked like that. So these are all of the main syndromes, and there are more too. So these ones at the bottom are also really important genes, and there are several others. Now, the reason I have MEN1 in purple is that is actually the gene associated with the PNET, so the endocrine type of pancreatic cancer. And PRSS1 is associated with hereditary pancreatitis. So there are families where we have a lot of people that we're seeing with pancreatitis, and then others who didn't have this pancreatitis but got pancreatic cancer. So the thought is maybe they had some underlying pancreatitis. So that is something that we also want to include on our panels. So this is a good idea of what we test for. Now, the reason that we want to test all of these genes is because all of them have recommendations that would change a medical plan, both for the patient and for the relatives. And those might include earlier or more frequent screening tests. So I'm sure you've heard of endoscopic ultrasounds and MRIs for pancreatic cancer, and then there are many others for the other cancers involved. And medications for prevention, lifestyle changes, and sometimes surgeries to remove organs that are at very high risk. Now, all of that this is a big discussion that will be had with a genetic counselor or other genetics provider or healthcare provider, and it's really a shared decision that gets made. So another reason it's really important to have this information is that in recent years, the whole targeted and precision medicine cancer field has really evolved. And one of the things that we talk about is PARP inhibitors, because this is a type of treatment that actually preferentially kills cancer cells that were caused by BRCA mutations in people who have a germline BRCA variant. So this is something, and we've selected over normal cells. So it's really exciting that it's been proven to be pretty successful. And then immunotherapies. This is when we can prime somebody's natural immune system to fight the cancer cells that are caused by mutations such as those in Lynch syndrome. So people who have Lynch syndrome have a better reaction to this type of therapy. So it's really important to know this because it actually may change someone's treatment. So then who in a family should get tested? So now I'm gonna teach you how to think like a genetic counselor. So let's say this man comes in, he's 62 and he's recently diagnosed with pancreatic cancer, and this is his family history. This is a chart called a pedigree that we use to look for patterns in the history. So let's say that his son comes in and to get tested because he's worried about his risk for pancreatic cancer. Well, we could test his son, but if his son is negative, it doesn't tell us why he's negative. It's good that he's negative for all these pancreatic associated genes, but we don't know if he's negative because he inherited his father's normal copy or if his father didn't have any mutations to begin with. And so what I would say to him is if we can test his father, we'd like to do that because his negative is what we call an uninformative negative. So again, it's still good, we know it's negative, but it's not complete, it doesn't tell us the whole picture. So who do we test? I would recommend testing his father because he's the one who's most likely to have a mutation if there is one in the family. And we would test him with something called a multi-gene panel. So it used to be that we would only test one gene at a time, but now because of the cost of testing and the technology, it is much faster and more cost effective to test many genes at once. And it's really helpful for individuals who may previously have tested negative for one or two genes. And as more genes are found over time, they're added to these panels. So even someone who's tested 5 years ago or 3 years ago, there may be some new genes that have been recently discovered and were added to the panel. So it's a good idea to kind of keep in touch with your genetics provider to make sure your panel's up to date. So let's say we test his father and we find that he does in fact have a mutation in BRCA2, let's say. Well, that's actually great now because we know exactly where that genetic change is and we know exactly who is at risk. So we can then test each of his first degree relatives who are each at 50% risk. And anyone who is negative in this case is called a true negative. And that's because we know what we're testing for and we know that that person didn't have it. So this is when we can really figure out who is and who isn't at risk. Now, of course, in pancreatic cancer especially, many times the person who has had the cancer is no longer testable. They're no longer living. So the next best thing to do is to test all of the first degree relatives, because if this person was negative, well, we still don't know, again, if there was something in the family. So we would want to test anybody that might have a mutation. So let's say we test this man's aunt and the sister of the man who had the cancer, and she's negative. Okay, great, but we still, again, don't know. So at this point, we would be recommending that, or we'd assume that these people have a slightly increased risk because they have a family member who's been affected. So we test more people. And then finally, we test the brother, and he actually has mutation. So now at this point we know, okay, that most likely came from dad. And what we can do is test mom. And if she's negative, we know for sure that that came from dad. And most likely that's what caused the cancer. So at this point we know who is truly negative and who's truly positive. So this is kind of how we think about it when we're working with the whole family. And so if, let's say, everyone's negative, well, it's more likely that there probably wasn't a mutation just because it is less common to have one. So we would screen based on family history and not on genetics. So that takes me to tip number 2. If you're meeting with any genetic counselor or provider to determine your risk for any cancer, try to get any genetic testing results that anyone in your family has taken, because even negative results, they're just as helpful as positive. And we want to know which genes have been tested for. And so if you are having issues or your doctor's having issues actually ordering testing or getting it covered, the most recent National Comprehensive Cancer Network, or NCCN, guidelines actually indicate that anybody with exocrine pancreatic cancer at any age should be offered germline genetic testing. And below it actually says that affected or unaffected relatives should also be offered it. And it's recommended it's a first degree relative. And then there's also something that says that there's significant benefit to family members in testing patients near the time that they're diagnosed. So that brings me to my research that I did at UCSF. So typically when somebody is diagnosed with the pancreatic cancer, because the prognosis, they're typically diagnosed later and the prognosis isn't as good, we don't get a great uptake of genetic testing in this patient population. So we looked at the traditional model and then we developed a new model. And we were actually able to, we called it the genetic testing station, where we were able to test people when they were diagnosed. And we had a huge increase in the number of people that were tested. And so that actually gave us a good kind of look into the amount of people that would test positive. And what we found after doing a really large germline panel is that 11% of all of the people diagnosed with pancreatic cancer, regardless of their family history, 11% of them had a mutation in a gene that had NCCN guidelines for medical management. What that means is that 1 in 10 people we tested, their medical plan changed because of the genetic test that was done. So this is more, proof that it's really important. It can be really important both for the patient and the family. So just a few points to remember. Having a mutation in a gene, a cancer gene, does not mean you have cancer, and it does not guarantee you will ever have it. It just means that you have a higher risk for developing it. This knowledge can help you be more cautious and catch anything early so it doesn't become dangerous. And most people who do testing, who undergo genetic testing, will not have a mutation. Remember before we talked about sporadic, most of these cancers are sporadic. They're not associated with an inherited mutation. And even if there is one in a family, there's really only a 50% chance that the first degree relatives will get it. So most people will not have one. And then genetic counselors, if you do have one, are your go-to to help you understand what that means and work with your doctors and make sure that you're not lost and confused. Now, something I get all the time, these questions are insurance and coverage. Is this going to be covered? So before I go into that, I just want to note the Affordable Care Act prohibits insurance companies from using pre-existing conditions to affect coverage. I know because of the current political environment, that might be something that people tend to be worried about. But there's also something called GINA, the Genetic Information Non-Discrimination Act. And this is an act that's there both at the state and federal level. It helps prohibit health insurance discrimination based on genetic test results, and that's for health and employers. And so that really protects somebody. They can't be denied insurance if they have a mutation. And the test itself will be covered by commercial insurance, Medicare and Medicaid if somebody fits the NCCN guidelines, which is everybody with pancreatic cancer. And they will also cover any screening. So if somebody has a mutation and they need screening or they need surgeries, well, insurance will cover it because they have that mutation. So in a way, it's a ticket to get those things covered if you can show that you have one of these mutations. So if you are interested in seeing a genetic counselor, seeing someone like me in a clinic, go to findageneticcounselor.com. This is a really great website where you can find somebody to speak to. Right now, it's all telehealth because of our pandemic, which is also, it's great to be able to do that. And they can actually send you a kit from home if you need to get tested. And I'm really excited also to share that we've given the family intake form a facelift, and it's now this really great, beautiful form that you can look on the Ralph website. So now I will take any questions. Oh.
Sometimes it helps if we unmute ourselves, especially after being on Zoom calls all the time. Anyhow, Dena, that was amazing. I love how you broke down such a intricate topic into things and ways that people can understand in an easy, accessible way. So I greatly appreciate that. We've had a lot of questions coming in, so I want to get to them. We've had some that come in through the chat and some of folks who have emailed to us. So our first question comes from Rachel, who's asking, how do we decrease our chances if we have familial cancer?
Yeah. So familial cancer would be that middle category where we aren't sure all of the things that cause a cancer. And so when we talked about those risks on that that page I have with the smoking, the alcohol use, so quitting smoking is a big one to decrease risk, big. Alcohol use, really limiting it if possible. Exercising, as much as you hear this from your doctors, exercising and having a healthy diet are really important. So really the whole lifestyle thing is very important, and trying to avoid, situations that you might be exposed to strange chemicals, which doesn't come up often. But really just putting yourself in a good situation with a good lifestyle is going to be the most helpful.
Great. Jeff is asking, if I have only one family member, his father, who had pancreatic cancer, is that sporadic or familiar?
Yeah. So we don't know, because there is a large amount of pancreatic cancers that, like I said, 1 in 10 that may have one of these mutations. Even if we don't see a family history for pancreatic cancer, we still recommend testing. We don't know if it's sporadic or familial or hereditary at that point. Most of the time, if it's a different type of cancer, so one that is more common and less often genetic, such as lung cancer, we can say that that's sporadic. But when we talk about pancreatic cancer, it's more often, we can do more if it's hereditary, so it's better to really test to see what it is.
Okay, great. Here's an email question that came in. In many studies, it shows that Black Americans are the demographic with the highest risk for pancreatic cancer. What role do genetics play in this?
Yeah, that's a great question. So when we talk about someone's ethnic role, with the exception of Ashkenazi Jews, because there's the founder mutation, it's really a mixture of environment and genetics together. So cultural, the things people do, the things people eat, the way people live, socioeconomic class, their access to healthcare, and also the shared genes. So not just one gene, but all these different genes that act together that people of the same ethnic group may share. So all of that together may increase a risk for a type of cancer.
Great. Okay, now we have from Alyssa, and Alyssa, thank you so much for sharing, and I'm very sorry for your losses. My father died of pancreatic cancer in 2011, and my mom currently has metastatic leiomyosarcoma, and her sister died of leiomyosarcoma last year. I underwent germline genetic testing last fall and have variants of unknown significance in my APC and ATM genes. My genetic counselor told me to watch and wait. Is there any screening that I should undergo in the meantime? I was most concerned about the ATM variant and its possible link to pancreatic cancer.
Yeah, unfortunately, it's really hard when we find variants because most of them do get reclassified as benign. So it's looking at, as a genetic counselor, we have these tools where we can look at the variant and really sometimes just from experience, we can tell, okay, this is this particular change in this particular part of the gene. And sometimes we'll combine the clinical picture and maybe depending on the situation, there may be some recommendations, but more often than not, we don't make any recommendations. And it is unfortunately watchful waiting. The one thing I would say to that is, I don't know the situation, but what I would do is look at that panel. If a patient came in with this question, I'd want to look at what genes were tested. And I'd also recommend testing other people in the family to see if maybe someone else comes up with something positive. And then we would know if someone else had something positive that those variants mean nothing, right? Because we found the answer. Sure. But I think it's hard to really answer that question without really looking into a few other things in the family.
Okay, thank you. Are we close to identifying other genes that could lead us to earlier diagnoses?
Yes, every year there's new discoveries. So as I've been working, I worked at UCSF for the last 4 years. As I was there, every year, a few times, it was even maybe not even just once a year, maybe twice a year, we would update the number of genes on the panel. And I think the whole chronic pancreatitis, those genes may possibly be associated with pancreatic cancer. And another thing we saw is that people that had pancreatic cancer had higher rates of being carriers for cystic fibrosis, so the CFTR gene, which we know has function in the pancreas. So that's something that is also being studied across the world right now.
Okay.
As well.
So when Sherry wrote in that she has 3 or 4 risk factors, what next? What should she do?
Yeah, I think it depends. Those risk factors, if they're non-genetic risk factors, it would be helpful to meet with a genetic counselor and see if there are genetic risk factors, because sometimes the genetic ones kind of trump all the others if they're high enough. So if there are no genetic risk factors, then it's really working on what the risk factors that you have are and kind of looking more into those. Okay,
great. And on the genetic counselor front, you talked about findyourgeneticcounselor.com. And is there a high quality, a low quality? Are there concerns? I mean, are all genetic counselors created alike? What should be?
Yeah. Well, every genetic counselor has to go through the board certification process. They all need to go through training and rigorous clinical rotations. It's the same thing as any doctor. I mean, you'll have some doctors that you like and some doctors that you don't like, and maybe it's not a match for you, but it's good for someone else. Or, some doctors may just not be good doctors. It's the same thing. I mean, we're all human. So I think that the process of becoming a genetic counselor is the same, and it is rigorous. So it is difficult to become one. But I think that you have to think of it like you would think of any provider that you're going to go see.
Sure. How far back in our family tree should we look to determine the cancer risk?
Yes, typically when we take a family history, it's usually mostly first and second degree relatives, sometimes third. If it's further back than that and there's no other closer relatives with cancer, you have to think about how much genetic material do you actually share with those people, right? If they're distantly related, you didn't most likely grow up in the same place, you weren't exposed to the same things, and you only share probably a small percentage of your genes. So the further away that somebody is in your family tree, the less likely you share the same risks.
Okay.
So that's why we really mostly focus on first and second degree relatives.
Okay, great. And some follow-up questions on the genetic counselors. One is there a genetic counselor in Chicago that you would recommend specifically on pancreatic cancer? And Paul, I could let you know that at Rolf, we work with Christine from the University of Chicago. But Dena, if you have any additional folks that you could recommend, that would be great.
So I'm part of something called the Collaborative Group of the Americas for Inherited Gastrointestinal Cancer, or CGAIGC. They have a directory. So I think it's cgaigc.com, something like that. And anybody that's part of that is really, it's a very niche, cutting edge research organization. So if you really want a genetic counselor that's really involved at a national level, then it might be helpful also to look on their website, to look at their directory.
Great. And so they would have the access to the most modern testing and research and things that are out there right now, correct?
I'd assume so, yes.
Okay, great. Gail's asking, if I'm an Ashkenazi Jew and my mother died from pancreatic cancer at age 84, the only relative I know that died from pancreatic cancer, should I be tested?
Yes. Any Ashkenazi Jew, really what I say, even if an Ashkenazi Jew doesn't have a family history of cancer, there's 3 variants in BRCA1 and 2 that all Jews kind of, that because there's so much shared ancestry, that 1 in 40 will have. And so even when there's no family history, I always recommend someone who's Jewish get tested, at the very least for those few. But then when there is a family history, there definitely it's helpful plus the panel, just to make sure.
That's great. That's great. Thank you. Are there any questions that you typically get that have not been answered today? Like, how often should people get tested on?
Yeah. So typically, I think another reason it's great to test with the genetic counselor is because you can keep in touch with that person, and you can call. What I used to tell my patients, and now that I'm gone, there's someone that took over those patients. But what I would tell them is to call me every 2 years and just say, hey, are there any new genes? Can you look at my family history again real quick? And it doesn't take that much time to just open it up, look at it, see what was tested. And you just say, actually, yeah, we didn't test you for probably 2. You should come back in, or, something like that. So, so I think it's worth kind of keeping in touch and just asking your genetics provider every few years if there's updates. And it also is for the variants, the VUSs that I was talking about. Those get reclassified every year as well. And so it's worth asking about yours to see if there's more new information on those.
Great. So Paul's asking, if my dad and his brother both passed from pancreatic cancer, does that mean more risk for my siblings and me?
Well, yeah. So because you have more, when you have 2 people who had it, it is a little more risk than 1 person, right? Because then that's telling us that there's something they shared, whether it's environmental or genetic, that we don't know if you share, if the rest of the family shares. And so that is definitely a family that I would recommend that everyone undergo testing.
Okay, great. And how about the 23andMe kits and the kits that are out there? How are they?
That's what I was just going to mention. So sometimes I'd have patients that would come in and say, oh, I've been tested, I did 23andMe, but that is absolutely not a medical test. The way that technology is done is it only really looks at very specific points along random genes. The only one that's even related to pancreatic cancer is BRCA, and the only thing it looks at are the 3 points that are common in Ashkenazi Jews, and that even itself is not really a true medical test. So that is great for entertainment, but it is not a test, and it says everywhere on the site too. It is not a medical test and should not be used for medical decisions. So any at-home genetic test that you do, for the most part, if it does ancestry, it's not a medical test.
That's great to know. Any other insights that folks should know, and if you want to share again where people can find you?
Yeah. Oh, yes. So I forgot to put my email on there, but it's just Dena@denadna.com, or you can find me on social media as well. Feel free to send me an email, or if you have any questions. But I really recommend, if you even are thinking of doing testing, DenaDNA.com. DenaDNA.com. Yeah. If you are even thinking of doing any testing, to try to find a local genetic counselor, and it'll just make it a lot easier for you to be able to do that.
Great. Well, thank you so much for sharing all of your knowledge in such an engaging way. We'd like to encourage everyone to go to the website that Dena was talking about on the Rolf site, which is knowmyrisk.org, to fill out the form, fill out the Know My Risk worksheet, and connect with a genetic counselor near you. We also have a link to be able to find genetics counselors on the site as well. And we wanted to thank everybody here for watching and asking such insightful and vulnerable questions. We know that there's a lot that is behind this, and we truly appreciate your asking and sharing so that we can help everybody within our community. And if you're catching this on the replay, welcome. And be sure to write replay in the comments and mark your questions so that we can get back to you. And also, if you have any ideas for future Wellness Wednesday topics, speakers, please email us at info@rolffoundation.org. And check back for an update on next month's Wellness Wednesday topic and speaker. And until then, we hope you stay safe and take good care. Thanks again, Dena.
Yeah, and I have just one more thing to add too. Sure. That there is no such thing as a stupid question for anyone. This is a really complex subject. So even if you feel like, oh, this should be obvious, it's not to most people. And so if you are worried about asking something, in a form like this, or a genetic counselor, just ask it. Just ask it.
Perfect. Perfect. Well, thank you again, and we look forward to seeing everybody here back next month.
Thank you, everyone.